Thank you. Good morning. As billed, I'm a lawyer by profession and a non-executive director of the European Connected Health Alliance, and delighted with to be representing the Alliance today. So very quickly, when you talk about integrated care, there are lots of academic papers and publications on what it actually is. You'll be pleased to know I'm not going to bore you with that literature review. Instead, I'm going to give you a perspective of what it means to me, and those people who know me will know that I actually carry, if you like, a torch for the patient, the user, and I believe that that's my role in the Alliance, to actually articulate some of the challenges that those people face. So for me, it's less about what is integrated care, and it's about what integration. Because for me, this target, for those of you involved in health and social care, is remedial. Because as a user, you would expect your care to be integrated, to be coordinated. In other words, this is not an aspiration about something that looks fantastic in the future. This is something that most people would believe is their right as of today. So it is about the system playing catch-up to deliver what it should have been delivering, arguably, since the NHS was established in 1948. So the first thing is, it ought to be coordinated healthcare. In other words, primary, community, and secondary services. So that's the first plank in what I think integrated care is. The second plank is it ought to be coordinated, what's wrong with me? Coordinated health and social care services. And Martin Hayes, who's the next speaker, is going to talk about his experiences from another one of our ecosystems in Northern Ireland, which has an integrated health and social care system. And he'll tell you about what that actually means and some of the perhaps challenges that exist there. The third step is it ought to be coordinated health, social care services, and housing. Because housing has a lot to do with how well somebody is or not. So if you suffer from asthma and you live in a damp accommodation, your asthma is going to be unstable. But the holy grail is coordinated health, social care services, housing, and education. And for those of you who are from local authorities, this will be no surprise, because local authorities are responsible for both education and housing. So for me, when we're looking at real coordination, that's the challenge. And at the moment, we struggle to get health coordination, let alone some of the others. But the challenge for the ecosystem for me is to be following that agenda and trying to genuinely coordinate all four. And one of the opportunities that the ecosystem has is to get greater involvement strategically from the local authorities and from housing associations and other housing providers to join up this agenda. And for those who came to the last ecosystem meeting, there was a powerful presentation from Liz Page, who talked about the pathway of a letter. So if any of you have any doubt about why we need to pursue this agenda, just go and look at her presentation online again and understand why, from the perspective of an individual, we need to make this very real. So the challenges in England, what are they? Well, essentially, we've got separate commissioners of health. So CCGs and NHS England for the commissioning of other professional services outside of GPs, as well as special commissioning. And we've got commissioning by local authorities for social care services. So we then have separate providers of health and social care. And in that market, we've clearly got NHS organisations, local authorities, the third sector, in other words, charities and voluntary organisations, as well as the private sector. So what's the real challenge here? The real challenge here is silos, okay? So this is a failure to communicate between these organisations, both horizontally and vertically, in order to actually pursue this agenda. But there's something else going on. So I don't think, the elephant in the room, okay, is relationships. So the first one is the relationships between GPs and hospital consultants, which is not the best. So any real attempt to build integrated care services has to actually work at the relationships between doctors and GPs. And another relationship is between health and social care workers. So again, there is this, could be characterized by words like arrogance, lack of understanding, but at its most basic, it's a failure by various people to understand the roles and challenges of the other professionals trying to deliver health and social care. So it's a lack of complete understanding about how you deliver services that can be coordinated. Then there's the one that most people will be familiar with, the relationships between commissioners and providers, but in this context meaning both the commissioners and providers of health and social care. And then finally, the patient voice and co-production. That last one, very, very in vogue at the moment. Lots of talk about patient voice, lots of talk about co-production. But trying to get meaningful representation and involvement from not just expert patients. So somebody like me, so I have a long-term condition, I have asthma, so I can actually represent the views of asthma patients, but I'm not typical. How do you get the voice of mothers, young mothers who may be a single mother, or mental health patients? So there are challenging groups that it's not so easy to involve, and if you're going to really create coordinated care, you need to have those views as well. And in these relationships, okay, it's about creating honesty, transparency, and it's about creating trust. So these things are easy to say, incredibly difficult to deliver, and they cannot be built overnight. And I'll talk a little bit later about something called SLIC, which is Southwark Lambeth Integrated Care Project in London, where the stakeholders involved there are all of these stakeholders, and they've been working for 2.5 years at establishing some of those things. But for me, this is all about, okay, what is in the best interests of patients, families, and service users, not about what is in the best interest of a particular organization, whether that's a hospital, whether that's a CCG, whether that's a local authority. Now that's another thing, easy to say, very difficult to walk that talk. But it is really always about, if you're going to collaborate, you have to start to understand it's about what is in the best interests of the patient, the user. And in many ways, for me, as a taxpayer, for all the publicly funded organizations, I'm going, why isn't that the case? You may be sovereign bodies, but you're all using Dad's money. So actually, Dad would like it coordinated. Okay. So some of the workarounds in the system just that exist currently that people use to try and coordinate. So most people will be familiar with Section 75, where you have joint health and social care commissioning powers. Section 75 allows pooling of budgets between health and social care. And around the country, there are lots of good examples of starting to commission what are called integrated pathways of care. So that would be pathways that exist between primary and secondary care. In some instances, they might be integrated by also involving social care at the discharge end. There's been lots of talk in the last 5 years about vertical integration. So those with you with a long memory will remember that community nurses came out of acute hospitals went into PCTs. When PCTs were abolished, they had to find another home. Some of them went back into the hospitals again. So in the sense that if you have a hospital that delivers community care nursing, then you've got a sort of integrated organisation already. But the vogue is really integrated care organisations, lots of commentaries about that. For me, that doesn't deliver coordinated care. It's still about changing the way services are delivered. And organisational integration is just a simpler way, some see, to try to start integrating services. And then finally, there are high-level duties being imposed. The 2012 Care Act, not yet in force, but imposing greater duties between local authorities and NHS organisations to cooperate and secure integration. So the policy direction, regardless of what happens in the next election, is for more cooperation, more collaboration, some of which might turn out to be legally based. And finally, on the cooperation bit, lots of people will be familiar with the sort of language being used in the system is partnering of various descriptions. And then some of the commercial challenges to set the scene for today. So as a lawyer, this is really simple for me. This is about contracts and the allocation of an alignment of risk, reward, savings, income and profit, and trying to remove perverse incentives. So perverse incentives, for just as a simple example, when the hospitals are being remunerated by payment by results, they're incentivized to treat. If you have integrated and coordinated care, which leads to a reduction in treatment, then naturally the income of the hospital starts to reduce. That has a potential challenge for them. So that's an example of a perverse incentive. And the question is, if you reduce activity in a hospital, how do you compensate the hospital for the fixed costs that it's got in order to incentivize them to agree that reduction? So that's what this is about. I'd say that there's confusion in the marketplace between contract models, so for example, alliancing, and I'll come back to that in a second, and prime contractor and subcontracting, and payment mechanisms where you talk about capitated payments. So that's a fee per person to look after a person for a year. So for example, asthma patients for a year. And there's challenges around compliance, legal compliance with procurement rules and competition laws. So there are some stakes to negotiate when you're trying to deliver coordinated care. And then the final point, talking about a little bit about alliance contracting. So to give you a vision about where this may go. So back to SLIC. So SLIC is 2.9 million people, 2 London boroughs, and it's a partnership between 3 tertiary FTs. So Guy's and St Thomas's, King's Hospital, SLAM, South London and Maudsley, so a mental health hospital. King's Health Partners, which is the Academic Health Science Centre. Then the 2 local authorities, 2 CCGs, and King's College University, which is the academic institution inside the AHSC, sorry. And what this is about is trying to actually deliver whole system transformation through a vehicle, through this relationship where it's the entirety, the A to Z of health services and social care. So the most ambitious agenda anywhere in England on that scale. And what they're doing is they're creating an umbrella agreement, which is an alliance relationship, which allows them to use some of the tools I was referring to earlier on, like payment mechanisms, aligning risk and reward, in order to actually align and remove the perverse incentives and bring about whole system transformation. And the whole system transformation is on 12 months and on 10 years. The 10-year activities are basically public health, improving the health and well-being of the citizens of the 2 boroughs. So if you want to, there's clearly different agendas on integrated care, some very short-term 12, 24 months around financial challenges, for example, the reductions and massive reductions in social care services budgets, as well as long term. So I think that's my slot done. So that's the very quick introduction to the challenges. Thank you.